Hello. In today's video, we're going to talk about delivering unpopular messages to patients and when it's most appropriate. There are several types of scenarios which we would face clinically, and we need to identify them and make the most appropriate recommendations. First is somebody who is too acutely painful to do any proper physical examination or rehabilitation. And that can be somebody with an acute disc prolapse, a very severe whiplash, or of course if they've had major traumatic injuries, fractures and things like that. In that situation, there is no role for physiotherapy assessment. Now, sometimes people may misjudge the severity of their injury, and there might be what would appear to be a sprained ankle, but we could be suspicious of a fracture. So it is incumbent on the clinician to know the appropriate testing to do in order to recognize potential dangers and what needs to be done. The same would be the case with falls and injuries, where there could be an overlap between what would appear to be a soft tissue injury and a bony injury, because the management would be quite different. So that's one group of patients where one is suspicious of other potential pathologies that would be managed quite differently, or if the severity of pain is just precludes doing anything appropriate. So that's one group of patients. Another group of patients would be ones where they might have a history of a grumbly knee that flares up from time to time, or a sore back or shoulder, and usually responds well to treatment. But as time has gone by, the episodes of pain get more intense and they get a bit more frequent, and that usually tells you that there is progressive change happening in the tissues. And from a rehab point of view, we need to recognize when tissues have gone beyond a certain point of repair. So from a treatment point of view, we obviously aim to try and restore movement and reduce pain and improve people's functional capacity. But if you start to see a condition plateauing in its response, and people find that if they do a certain amount of activity, let's say they're a casual runner, and if they run over 10k, the knees or ankles start to get sore and take a couple of days to settle down, and they have followed through a structured rehabilitation protocol, then it does beg the question, is this, are these joints able to tolerate that kind of physical load? And from a physiotherapy point of view, as long as you've gone through sequential loading and have tried to optimize mobility and strength and flexibility and training regimes and all of the other factors and footwear and running mechanics that all go into trying to improve function, and if you've done all those things and there's still a finite tolerance for the activity, then one has to reach the conclusion that the tissues will not tolerate a certain degree of load. And that's usually not a popular scenario, because people might mean having to give up their chosen activity, whether it's casual tennis if it's a shoulder issue, or running if it's a chronic Achilles tendon problem, or golf if it's a chronic tennis elbow problem. But in order to come to that conclusion, you usually have to have guided people through a progressive sequence of loading, and then find the point where it plateaus. And then the question becomes, well, is there anything else that could be done? Is there a surgical solution? Some cases there are, some cases there aren't. Usually in chronic tendon issues, there usually isn't a great surgical alternative. If it's degenerative change in joints, sometimes it's possible to have a what's called a debridement or a cleanup procedure in particularly the peripheral joints, the shoulders or the knees, and the hips more commonly now as well than used to be the case. The spine is not really a great region for tidy-up operations. There either needs to be compression on nerve roots or spinal cord, which is very serious pathology, but there isn't really surgery just to try and improve the mechanics of the joints. So that's not an option. The other alternatives then are pain management procedures, which could be things like steroid injections into joints. So that's a strong anti-inflammatory. So that's something that can give people another boost, and may be the difference between being able to tolerate their chosen activity, or may just mean that there's less of a severe adverse response to doing things. And of course, in recent years too, there's also been an injection therapy called viscosupplementation, which is using injecting a viscous fluid, a sticky fluid like an oil into the joints. And for someone who's not at an end stage arthritic situation in a joint where it's not ready for replacement or something as radical as that, lubricant and joint injections, often done twice a year, can often buy them a few years more in terms of mileage in the joints. So that's another option. But it is important for a clinician to recognize, as people work through improvements in function in their rehab, if they start to observe a plateau, then the question is really, is this as good as it gets? And usually, if one is confident that you've explored all the components and there's no further potential for manipulating other variables and amalgamating things to try to improve function, well then, that is as good as it gets. And then the discussion needs to be had that the tissues will not tolerate it. There is a difference too. Some people don't necessarily recognize the difference between joint pain and muscle pain after activity, and that's an important thing to recognize, because joint pain after activity isn't a good thing. Essentially, you're taking mileage out of the joints, and it comes down to how do you want to use the mileage in the joints. Whereas muscle pain is a much less sinister problem. It can still be uncomfortable, but it's not a problem of progressive degenerative change. So the location of where you're sore after activity or exercise is important, because it tells you which tissues are involved. So it's never a pleasant conversation to have with people, because obviously, if our focus of rehab is to get them back playing tennis or kicking ball with the grandkids or hill walking, whatever their activity is, and it turns out that their system just won't tolerate those activities despite structured progressive efforts and rehabilitation, then we have to be realistic and say, look, your system won't tolerate this, or if you do keep doing these activities, you're going to need continuous patching up, and that'll get harder and harder to do as time goes by. And then people can make an informed decision as to whether that's how they want to use the remaining mileage in the joints, or would they prefer to keep functional and maybe switch activities up a little bit. So it's not a popular conversation. Sometimes it doesn't happen, and patients just vote with their feet. They get fed up, or they keep going around the therapy shopping looking for different approaches, and that's generally because there hasn't been a transparency in approach to management. So another slightly controversial topic in today's video. Hope you enjoyed it. I'll see you again in another one. Bye for now.